Hope you are too. Jennifer?
Hi, Jason. How are you?
Doing fine, thanks. Hope you are too.
We're all good. So it's 4 o'clock. Why don't we get going? So hi, everyone. Welcome back to another edition of Tumor Talk. This is the collaborative effort between Lenox Hill Neurosurgery and the Journal of Neuro-Oncology, where we like to talk to recent authors of published articles in the Journal of Neuro-Oncology. And today we are delighted to have Jennifer Moliterno from Yale with us discussing her recent work on meningiomas. And I'm not going to do it justice. So why don't you introduce yourself and talk about what you've done? Welcome.
Sure. Thank you for having me. Can you see my PowerPoint okay? Okay.
Yep.
Yes.
I'll move you guys over so I can see you a little bit better. So appreciate the opportunity to publish in the Journal of Neuro-Oncology. It's such a great journal that really guides a lot of our thinking in neurosurgical oncology. So a real honor to be a part of it. What I'm going to talk about today is type of bony involvement predicts genomic subgroup in sphenoid wing meningioma. And this is work that we recently published that basically I had noticed a trend in my practice of sphenoid wing meningiomas. And then when we looked at the underlying genomics, there are some correlations that I thought could be useful for people to look for as they manage patients with these types of tumors. So sphenoid wing meningiomas, we all know how common they are, roughly how common they are. And some of them can be particularly challenging due to their intimate association with the neurovascular structures. And they tend to involve the sphenoid wing and the bone itself to varying degrees. And you can see here, I think you can probably see my mouse, but this lady had an intracranial meningioma and then associated with this bowing into the orbit. That in particular, we tend to refer to as sphenoorbital meningiomas, with this impressive hyperostosis, encroachment on the orbit, again, that you can see in this imaging here. However, the cause of the osseous component and really the relevance of the osseous component is less clear. And the biological understanding of it has not really been understood. So in the last 10 years or so, the work from Murat Genel's lab here at Yale, as well as others, has really led us to understand the genomic landscape underlying sporadic meningioma formation and specific somatic driver mutations. And so just a quick overview of that, about half of sporadic meningiomas have a mutation, a somatic mutation in Nf2 with or without chromosome 22 loss. This can sometimes be associated with a SWI/SNP transcription factor gene mutation in SMARCB1 here, and this is known to lead to more aggressive meningiomas. Of the 50% that are not Nf2 mutated, the most common, as we look over here, have mutations involving TRAF7. This was a gene that was not thought to be related to neoplasia before this was discovered. And these tumors with these mutations in TRAF7 usually have a co-occurrence of a mutation in KLF4, which is one of the 4 Yamanaka factors, which can then lead to meningioma formation, or mutations in molecules involved with the PI3 kinase signaling pathway. Another signaling pathway that we see mutations for meningioma formation, hedgehog signaling, SMO mutation, SUFU, which is an inactivating mutation of that tumor suppressor, can lead to meningioma formation. And then more recently, POLR2A that we see here. And then SMARCB1 mutations can also be seen, particularly in clear cell as well as spinal meningioma. So that's just a quick overview of the somatic mutations, the driver mutations. Back in 2013 with the science study, the role that I played was really understanding the driver mutations and the relationship with intracranial location. And we further refined this in a publication a couple of years ago in the Journal of Neurosurgery. And so just again, quickly here, Nf2 mutations, we tend to think typically more laterally along the convexity. They typically occur more posterior to the coronal suture. We actually updated this figure in a publication that we just submitted to, another one that we just submitted to the Journal of Neuro-Oncology. So hopefully you'll be seeing that in the future. when they do occur more anterior or mid to the coronal suture or midline, they tend to have a co-mutation with SMARCB1. And then the TRAF7 mutated tumors that co-occur with either KLF4 or mutations such as AKT1, those tend to occur along the sphenoid wing. And so we knew that before from these other studies, and this study in particular really honed in on the sphenoid wing in particular. However, what we sought to understand better is the relationship of the bone in sphenoid wing meningiomas, and specifically with the genomic drivers. And so this was work that Lan Jin, whose picture is there, as well as Mark Youngblood, who's currently a neurosurgery resident at Northwestern, who did his MD PhD with us at Yale, did a lot of work for. And so we looked at histologically confirmed sphenoid wing meningiomas, all of which underwent whole exome sequencing, resected here. We then grouped the tumors based on whether they had Nf2 underlying mutation or TRAF7 underlying mutation, because those turned out to be the most common as we predicted. And then we also looked at radiographic classification of bone involvement, which I'll explain a little bit more on the next slide, and then performed our analyses. And so here what we chose to do was something really simple. We wanted to be able to apply this in real clinic time so that everyone could use this. And so what we ended up doing was just comparing the involvement of the sphenoid wing ipsilateral to the tumor to the contralateral sphenoid wing, using the patient as his or her own control. And so first you see in this one, which we ended up calling type 1, no bone involvement. And so here you see the sphenoid wing really looks very similar in appearance to the contralateral sphenoid wing. And this is again associated with the intracranial meningioma. In type 2, which is hyperostosis only, again, the intracranial meningioma. And you can see this thickening of the bone when you compare it to the contralateral side on CT and MRI. When we looked at tumor invasion, the way that we defined that was more of this soft tissue infiltration. So the enhanced tumor that you would normally see intracranially, this one really is just confined to an intraosseous type of meningioma. And then there could be a combination of the two, that there's some invasion of the tumor, but also just some hyperostosis and some increase in that bony contour as compared to the other. And then sphenoorbital meningioma, as I described before, really that frank hyperostosis of bone and the marked bowing into the orbit that we commonly see. So all patients underwent a standard approach that I typically use, which is a Terional Craniotomy. And then what I typically do, aggressively removing the sphenoid wing, drilling that down with an M8 drill bit. And for the sphenoorbital meningiomas, the ones that really had that encroachment on the orbit, such as this lady, oftentimes I'll enlist the help of some of my colleagues in plastics and oculoplastics who really help decompress that orbit, and we get a nice result in terms of the relief of proptosis as well as tumor removal. And so, as we anticipated, based on our prior work, most sphenoid wing meningiomas had a TRAF7 mutation followed by an Nf2 mutation. About 3/4 of these tumors had bone involvement. And the most common presenting symptom among all patients was vision loss or some sort of issue in terms of their vision, proptosis or diplopia and such. The mean follow-up period was about 38 months. When we looked at correlations between bone involvement and other patient and tumor characteristics, we found that tumors with invasion, so that's either with frank invasion of the tumor or invasion and hyperostosis, were more likely to be of higher grade, and they were also more likely to be larger when compared to tumors without invasion. The sphenoorbital meningiomas were found in 9 patients, and 8 of those were classified as hyperostosis, whereas 1 also had some frank tumor invasion based on the soft tissue radiographic feature. The sphenoorbital meningiomas were exclusively seen in women, and not surprisingly in patients who presented with proptosis. Nf2 mutant sphenoid wing meningiomas were more likely to have bone invasion, older age at surgery, and a larger tumor volume, while TRAF7 mutant tumors were more likely to have hyperostosis only and a smaller tumor volume. This was an illustration histologically. So unfortunately, with my approach, a lot of times, and given that this was a retrospective review, a lot of times I will just drill down the sphenoid wing, and only now am I really making sure that when to bite it off and to sample the tissue and send it to pathology, so we have more of these confirmations and illustrations such as this. But what we found here was a good representation of an Nf2 mutant sphenoid wing meningioma. You see here the bone itself from the sphenoid wing, and then here that frank tumor infiltration, as opposed to a TRAF7 mutated sphenoid wing meningioma, which you really just see that bony overgrowth and a histological equivalent to that. When we looked at sphenoorbital meningiomas compared to non-TRAF7 mutated tumors, those with TRAF7 mutations had higher percentages of sphenoorbital meningioma, though this was marginally significant, likely because of that small number set of these tumors. But it was found to be a strong predictor of TRAF7 alone. And again, 8 of the 9 patients had hyperostosis only and was associated with TRAF7. I think this is probably the most relevant of all the slides and summarizes the work the best. And so looking on the left in A, we found that tumors with invasion, this is either tumor invasion of the infiltrative component of the tumor and associated with hyperostosis, were nearly 30 times more likely to harbor an Nf2 mutation. And this was after we adjusted. And on the contrary, a hyperostosis only without frank tumor invasion were over 4 times more likely to have a TRAF7 mutation. So again, the take home is when we see an MRI, see an image with a scan that's involving frank invasion of tumor into the sphenoid wing, we tend to be concerned that there's likely an underlying Nf2 mutation, whereas those that are sphenoorbital and really associated with hyperostosis and the bowing into the orbit, we tend to think more that it's likely to be a TRAF7 mutated tumor. We did comparisons between machine learning models, and basically it's a little bit of a busy slide, but what we found out was that there was a tenfold cross-validation. And so logistic regression models outperform the other models. And so the take home to this was that what the numbers reveal is that the accuracy with being able to predict what I just mentioned was really sound. So in conclusion, bone involving can predict underlying genomic subgroups. Sphenoid wing meningiomas with invasion are nearly 30 times more likely to harbor Nf2 mutations. Tumor with hyperostosis only were over 4 times more likely to have underlying TRAF7 variants. What does this mean? So we last fall published in Neuro-Oncology our previous work with regards to recurrence. And so as we all know, Nf2 mutated tumors, as I briefly described, have a biological pathway to forming more aggressive meningiomas. And what we found in the Neuro-Oncology paper was that was the case, and that is typically driven through its association with atypical features rather than the mutation alone. However, what we also found were that the TRAF7 subgroup also had an increased risk of recurrence. And that group, the Nf2 TRAF7 subgroups, was part of a more aggressive type of meningioma subgroup, had an average rate of 22 times higher than others. And so what does this mean? I think in my mind, when I see a tumor that has a sphenoid wing meningioma that has tumor involved with the bone, I think it's important to remove that. I think right then it can tell us that it's more likely, or could be more likely, to be a higher grade or at least a more aggressive genomic subgroup. You can also argue, with hyperostosis, that would draw the same conclusion, especially if we're saying that TRAF7 mutant meningiomas tend to be more aggressive with higher risk of recurrence. But I think the relationship with the hyperostosis is a little bit less clear. And I think more work, which we're doing right now in the lab, to understand the relationship with TRAP7 and hyperostosis would be really valuable as well. Regardless, for those TRAP7 mutated tumors, they tend to really be associated with visual issues, and aggressive decompression would be beneficial regardless. I just wanted to acknowledge again Lan Jin, who did so much work for this project, as well as Mark Youngblood, and all the other members of the team, as well as the people in my lab, Marat's lab, and everyone in our primary brain tumor surgery program here at Yale. And those are my two favorite guys a few years ago. My son is a little bit bigger now, but they're still my favorite guys. And then also, just to let anyone watching who's interested know, we do have a Neurosurgical Oncology Fellowship here at Yale, and we are open and looking for applicants for July 2022 and July 2023. So feel free to email me with any interest. Thank you.
Thank you, Jennifer. That was great.
Great talk. I agree.
I mean, like anything good, it just sparks so many more questions, right? And we could go on, I'm sure, for a long time. So at this point, we'll open it up for any audience members who have questions. I kind of want to just dive right in, if you don't mind. In general, it sounds like this has changed your practice such that if you see hyperostosis now, the sphenoid wing, whether it's, I imagine middle third or lateral third, you're more inclined to remove that. Is that true?
Yeah, it is. And we actually looked, because I was curious too, to try to see whether or not we would see a relationship kind of along the wing as we went from medial to lateral, because the Nf2 mutated tumors tend to have a lateral gradient. And we didn't quite see that at the skull base. And it could just be because we needed more numbers for the non-Nf2, I don't know. So I think that's something to still look at. But yeah, I think that this is a quick and easy way of trying to infer what you might be dealing with up front ahead of surgery and the biological implications.
My question to you is this, it sounds like, based on my understanding anyway, is that just having these mutations alone, which are more common in this location, does kind of imply a higher grade to these lesions. And so, not everyone, I think, will immediately radiate these. And some people obviously would. So in addition to, or instead of that total resection, would you think that something like gamma knife up front or stereotactic radiosurgery up front might have a benefit? Or do you think that the grade of this implies that it's going to come back kind of regardless? You should do your best surgically.
So usually I think, so just to specify a little bit more, so Nf2 mutations are typically associated, or they can be associated with higher grade, and they're along the pathway to more aggressive meningioma formation with chromosomal instability or SMARCB1 co-mutation. The TRAP7 mutated tumors tend to be grade 1s. So those can be the ones that are associated with an AKT1 mutation, and what we saw in the Neuro-Oncology paper is that those can recur in a short period of time. So those can be the ones that you get the histology report that they're grade 1, and then they pop up, a year later, and it doesn't make sense because they're not following the rules. And so we're fortunate here that we do whole exome sequencing on all of our tumors. And so to answer your question, I typically, I don't use radiation up front. I usually will use surgery. But the question as to whether or not to radiate postoperatively is one that we've been using genomics to guide us more and more. And of course, with Nf2, if it comes back as grade 2, we usually will favor radiation just as part of the treatment. But if it comes back as a grade 1, but there's some concern whether there's, chromosomal instability, or there's, like I said, the AKT1 mutation or something like that, we will use that to determine whether we might give upfront radiation or at least follow them much closer.
As I listened to the presentation, I had previously read the paper. I think it's impactful, and I think one of the things that I'm most impressed on is that you're really, much like we do for other types of brain tumors, letting the mutations drive your therapeutic decision making, and in essence personalizing the treatment approach, not based solely upon MRI or age or gender, although you did show that there were more sphenoorbital meningiomas in women than men, which may be in and of itself an interesting hypothesis to sort of explore. But thinking about the adjuvant therapies that may follow or lack thereof, and watchful waiting and active surveillance. I was going to ask you a slightly different question, and I don't think was encompassed in this, but since you are an expert in meningiomas, you and your team up there, I'm oftentimes referred patients like you've sent and discussed in this paper, but also in instances, patients with sphenoid meningiomas with some degree of bony and or invasiveness to the sphenoid that have had previous radiation. Mm-hmm. And I wonder what your thoughts are, along those lines too. Probably resection, and then following it potentially with some more adjuvant therapy. But do you alter your thought process and treatment when they're post-radiation induced meningiomas? Because I presume most of these were not that, they were sporadic ones.
Correct. Yes. And so you're talking about patients that were managed by radiation. The tumor was managed by radiation, not patients who had radiation as a child or something.
Yeah, no, the latter actually. Patients who've had previous radiation as a child, maybe for a medulloblastoma, and then lo and behold, they developed a sphenoid meningioma. And there's a whole sort of set of genetic mutations that have been linked to radiation-induced meningiomas. What if any, insight could you give on those challenging patients? And do you think that their mutations may be different, and your approach, is it in any way, shape, or form different for those types of patients, albeit much more rare than sporadic sphenoid meningiomas?
Absolutely. And so those patients we typically, as you said, exclude from these studies because they have the prior history of radiation. Having said that, we still will perform whole exome sequencing, and we still have some insight into that. And as you said, they do tend to have more specific mutations in the sense that from what I've seen and understand, they tend to have Nf2 mutations. They tend to have a very unstable profile, and the chromosomal instability is likely what's driving that aggressiveness. And so the way that I frequently manage those, of course, I would say, when we see them, it's usually somebody who, like you said, had some sort of childhood cancer, got radiated, and then years later, they're not having surveillance, and then they come back and it's this huge, nasty tumor that really just needs surgery. And so I think the approach there is still very similar to this, that I treat them as aggressively as possible from a surgical standpoint, and tend to be as complete as possible from a surgical standpoint, understanding with those tumors that there's going to be some disease that we're not going to be able to get. And then usually we do follow that up with adjuvant therapy.
Jennifer, running with the idea of adjuvant therapy, have you looked at targeted kind of chemotherapeutics or biologics that can address these mutations as something to consider after resection for maintenance of disease or prevention or recurrence?
So of course, the clinical trials that are out there currently are looking at more targeted treatment. And that's something that we support with our patients being enrolled in, especially for those more challenging tumors. I think a really interesting question that I always have is what is the role for radiation in those patients? And that's something that a trial has not yet been developed. But I think that would be something that it might be a little bit more challenging to do, just logistically, but I think that would really be insightful. When do you radiate the grade 1s meningiomas that just don't behave like grade 1s?
Yeah, absolutely. I'm checking to see if we have any questions from the group real quick.
Looks as though you've got some responses, but in general, great presentations and other sorts of things. One additional question with the sphenoorbital meningiomas, you had indicated that there appeared to be some gender predisposition. Women being more afflicted with them. That's been my experience too, interestingly. And I don't know about yours, Randy, but I wonder, I mean, have you, is there any ongoing lab work that may look at that? I know there's been a lot of interesting hormonal driver research over the years has been done with meningiomas. My guess is some in this audience might be particularly interested in your thoughts, leading a lab and also being a neurosurgical neuro-oncology practitioner about gender-based drivers that may relate to these meningiomas, especially some of the more aggressive ones.
Yeah, absolutely. It's funny that you say that, because that was something that I noticed in my practice. You know, all these patients seemed like they were women, and then it turned out to seem that way too. So I can't imagine that that's a coincidence. And I think understanding the relationship, as you said, is exactly what we're hoping to do. And so that's something that is ongoing in Murat's lab, as well as other affiliated labs here, in terms of, like I said, looking at TRAF7's role in particular, because that was a gene that was really poorly understood in terms of neoplasia before its role in meningioma formation. And then, as you also said, continued in ongoing work in terms of the hormonal receptors, I think is another area, and seeing the relationship between the two. That's definitely something we're interested in looking at.
Absolutely. Well, Jennifer, we try to keep it to a half hour. And so we're kind of wrapping up real quick. I think it's super fascinating stuff. I think people are just beginning in the last maybe 5-10 years to become interested in this and meningiomas and how we can use this to kind of transform our treatment paradigms. I find it totally fascinating that the genetic mutations are related, specifically to the bones on which these things arise from. It doesn't make a ton of sense to me, and I try to wrap my head around why that would be. And maybe it's almost a congenital thing, how your bones develop and how the arachnoid over these things are influenced by their microenvironment. I don't know if you have any insight into that or any final words, but really a pleasure to have you here.
No, it's wonderful to be here. I think, meningiomas have always had this rep for being, benign tumors. And I think they really can be anything but. And the fact that they tend to be more homogeneous, not a lot more homogeneous, but more homogeneous than other types of tumors, I think really lends to understanding them better. I think there's still a lot to understand, but I think it's really important because you guys know just as well as I do, you have some of these meningiomas that really get out of control, and patients have no options, and they're even worse than glioblastomas in certain situations.
We certainly need better medical options for these, and I think your work it's already provided a lot of insight, and will likely lead to some lines of attack for these medically as well as surgically. So thanks so much. It's been great. We'll see if your son, it looks like he's already part of the team. Maybe he's a budding neurosurgeon to follow his parents.
Yeah, the residents try to get him to hold the pager, but he's only 6 years old, so not quite yet.
Just give him a couple years.
Yeah. Thank you so much for the opportunity.
Thanks.
All right, everyone.
Great to see you both.
Thanks for tuning in. We'll see you next time. Have a great afternoon. Bye-bye.
Thanks, Randy. Bye.